Okay, welcome to our course entitled Complications After LASIK and PRK, Achieving Excellent Outcomes in Therapeutic Corneal Refractive Surgery. The presenters are all individuals who work together with me at the London Vision Clinic in London, and I will introduce them as we come through. Mr. Glenn Karp is my associate surgeon. Marine Gobet is a PhD optometrist who's worked with us for close to 10 years, let's say, and her PhD is in wavefront sciences and analysis of normals and keratoconics, but she works full-time really on our research now. And Tim Archer, who's been with me for almost 10 years now, more than 10 years, and his pupils are 9.23, I think. Yes, world record scotopic pupils. We've been working together. Tim has a degree in mathematics from Oxford and computer science from Cambridge, and he has an honorary degree in ophthalmology from me, as you will see later when he starts to speak with you. My financial interest is, particularly to this, in relation to this course, is that I developed the Artemis technology with colleagues at Cornell University coming up to 20 years ago, sorry. And this is not a commercially available product yet. There's a lot of hope that things can be done with OCT rather than ultrasound. There are things that can be done by OCT rather than ultrasound, and we do. We have OCT in our clinic. We use it regularly. But there are things that only ultrasound, high-frequency ultrasound, can do, and you might gain an appreciation for that. Also, I'm a consultant for Carl Zeiss, and I've been so for 10 years, and I use their laser and their laser suite for effectuating repairs. So this course is really about how we use lasers to repair corneas that have had complications. It's not about intraocular surgery to compensate for errors. It's not about putting rings in for ectasia or cross-linking for keratoconus with simultaneous topography-guided treatment. It's specifically about how a refractive surgeon can use his tools to repair the complications that he may generate in the course of his practice. I think it's very important for us to define something right at the beginning, which is what do we mean by visual complications? Because we've all seen topographies that are very decentered and the patient not complaining. So what we're talking about here is the difference between what, on the other hand, some surgeons might say, but you see 20/20, and the patient says, but it's not clear. That's the other end of the spectrum. And obviously, loss of contrast sensitivity, measuring contrast sensitivity, in my view, is a critical component to being a refractive surgeon at all, because someone might start with low contrast, and if you decrease that a little bit, you could tip them over into being non-functional. So contrast sensitivity is something that really, it's part of the visual function assessment of a patient before altering their optics. How you define what a patient sees, we use this simulator that was on the surgicaleyes.org website 15 years ago, and it enables us to at least reconstruct with the patient in the room what it is that they're seeing. We also have a test called the subjective point spread function test, where we refract the patient as best as we can. We put the Worth 4 dot up at the back of the room. We mask everything but the white dot of the Worth 4 dot, and through the best correction, we have the patient draw what they see around the light. And this is a very useful test because the point spread function that the patient sees is very different often from the point spread function of the aberrometer that draws the point spread function of the patient based on the aberrometry. Because the aberrometry is about the optics of the eye, and actually what we really care about is what are the optics of the mind, because that's where the image is created. Many of us have coma, but we don't see coma because we are filtering the coma. So it's very important to understand what the patient is seeing himself. And just a philosophical point here about, it's interesting that this course is so full because I taught this course at the ESCRS 10 years ago, and there were 4 people in the room. And I think that there is an increased momentum in understanding that as refractive surgeons, even though the percentage of patients that require highly sophisticated thinking and highly sophisticated tools to repair a complication, even though it's a very small percentage of patients, it is very important to, not just to the patient, but obviously even to our practices, because one terrible result ruins your life. I mean, I can speak from experience. It makes you feel terrible. This is something which the industry needs to have pressure put on them for. And so this is kind of like my little philosophical soapbox part of this course, which is that you have to understand that industry has little to no interest whatsoever in investing millions on research and development for repair tools, because the number of people who would need these tools is less than 1%. And they don't see it as a buying decision item in the view of surgeons purchasing their equipment. And you, as individuals, need to start putting pressure, as I have, on companies to realize that they are failing to monetize their investment in the first place, because we have only penetrated less than 1% of the refractive surgery potential market. And we've been around for 20 years. And our results are ridiculously good, right? 95% 20/20, including enhancements, for whichever platform you're using. And it's not because we're going to make that 98% 20/20 because the laser is faster and has more tracking dimensions that people are going to go up from less than 1% to 2% penetrance. It's because people feel that there is a safety net that if something goes wrong, it can be fixed. That is what's going to get the other 99% of people to consider refractive surgery. Not whether it's 98% 20/20 or 94% 20/20 or 77% 20/20, which is what it was 15 years ago when we started doing this. Okay, I'll get off my soapbox. So, let's get down to some hardcore. I have to go through this with you even though you can't do it, because really, to understand complication repair, it's like any part of medicine, you need to have a diagnosis before you can prescribe a treatment. And so, excuse me, but you do need to understand what we're going to be showing you all afternoon. These are B scans. This is a B scan of a cornea that's had LASIK. This was done in 1998 in Vancouver. So you can see here a scan at the front of the cornea and the back of the cornea. The thickness of the lines is just the amplitude and the width of the echo. So obviously these are infinitely thin interfaces that are represented by ultrasound as a thick line. But we digitally detect the peak of this A scan in each of these composing the B scan. And here's the front of the epithelium, the back of the epithelium, and the LASIK interface. And we're able to measure the epithelium with 1 micron precision in 3 dimensions. We've been able to do this since 1992. We take meridial scans, and we can obviously scan people before and after surgery. We can see micro irregularities in the bed. We can see inadequate apposition of the edge of the flap. Here's Bowman's, not quite opposed. We can see a lot of detail. We have studied and published the precision of this very, very scientifically. Our ability to localize one of these surfaces within the cornea is less than 1 micron. It's 0.87 microns repeatability for localizing each interface. It's a very, very precise way of making measurements in the cornea. This is what we call a C12 display, a 12 corneal map display. This is the pre-op epithelium, stroma, and cornea. This is the post-op epithelium, stroma, and cornea. These are scales which are thicker is red, thinner is blue. You can see that the myopic ablation has caused thickening of the epithelium in the center and thinning of the epithelium in the periphery. That is shown clearly by this epithelial change map from pre to post. You see thinning minus values in the periphery and thickening in the center. We have the stroma before and after, the change in stroma, thinning in the center, but thickening of stroma in the periphery, which I will talk about in a second. We have the original flap that was created at the time of surgery, which is a combination of the stromal component of the flap plus the preoperative epithelium. That's the actual flap created by the device. Because the post-op flap, which is up here, includes the epithelial change. So all these studies about flap thickness using an OCT measurement are measuring from front of the surface to the interface, are including the epithelial changes. That's not an accurate representation of what thickness the flap was. And of course we have the residual stromal thickness in 3D, and we have the minimum, and we hope if I can find where it is, it might not be in the center. So as you can see, there isn't a part of the cornea that we're not imaging and that we can't measure, and therefore we're able to make diagnoses and therefore able to prescribe treatments in a way that we couldn't if we didn't have this internal information. As you all know, RTView has done a fantastic job of producing a commercially available device that with non-contact scanning can make a map of the epithelium. It maps the corneal thickness and the epithelial thickness, and they plot it, and they put micronic averages by region. Some of the disadvantages for us trying to do this all the time is that it only reaches out to 6 millimeters, which is often not enough for us. And the other disadvantage is that each pixel that you move on the screen is 3 microns. So even though you can measure something, it has a very high repeatability, because if you measure the same cornea 10 times and you have an algorithm that detects the edge, well, the algorithm is always going to detect the edge in the same place as a computer program. So obviously you get very high repeatability. But because the step size is large, 3 microns per pixel, we really don't get the sort of accuracy that we need sometimes when diagnosing problems, as you will see as the course goes on. But hopefully this will also improve in terms of technology. Now, the main areas that we're going to cover today are really the real problems that face, I would say, 98% of all the complications that we will have to deal with. And obviously dry eye is the number one, but we're not talking about that today. The 3 physical ones are high spherical aberration, otherwise known as small optical zone, decentration, and irregular astigmatism, because decentration produces regularly irregular astigmatism. And so we're talking about RK, microfolds, flap complications, short flaps, irregular ablations. All of these very unusual things is a rag bag that we will call irregular ablations. So I'm going to introduce the concept as to how spherical aberration is a problem and why it occurs. And we know from 10 years ago now of a very elegant paper that was published by Michael Mrochen and Theo Zeiler, where they made calculations about the influence of the fluence losses due to projection and reflection errors. And meaning that this intended ablation profile was degraded as we go out towards the periphery. Some people, I think AMO calls it the cosine rule. But this influence of loss of ablation in the periphery was thought to be, by them, a physical argument based on projection errors. Our work, right around the same time, where we published this paper in 2000, where we measured the stroma before and after LASIK and did a difference map and found that the stroma thickened in the periphery of the ablation. So in other words, we took tissue out of the middle and the peripheral cornea thickened, and it was the stroma thickening, not the epithelium heaping up or anything. And we showed this in 2000, and we showed that the effect of this would be far higher than the effect of projection losses. In my estimation, it's about 85% of the effect comes from just the biomechanical expansion. In this particular case, this is a 0.35 micron spherical aberration induction just because the periphery of the cornea is expanded and it's pulled everything up in the periphery and made the zone smaller. Cynthia Roberts, as this is what you all know, she published an editorial to accompany our article in which she said that the cornea is not a piece of plastic, and that's now a famous statement, and it isn't. We get this change in stroma in the periphery when we get thinning in the center, and her description of vectoral forces that could produce some central flattening and all these other things go along with the increase in spherical aberration that we see in all myopic cases. I mean, here's 8 examples of this. It's always happening. It's always happening. Okay? The peripheral thickening is, of course, accompanied by epithelial thinning, because the epithelium always changes to compensate for stromal surface changes. And this is something which will be a recurring theme throughout the afternoon in showing you that the normal cornea, the plain normal cornea, has actually not an even epithelial thickness profile. Particularly important for those doing transepithelial treatments. This is the epithelium. You're inducing coma because you're going to break through superiorly first, right? So the epithelial profile, not even in the normal, is even. And, of course, in keratoconus, which we've published, it varies according to the severity of the cone. In ectasia, in a similar way, you have thinning surrounded by a thicker periphery around the ectatic part. Obviously, myopic treatments, hyperopic treatments where the epithelium is filling the trough where we cut out. Radial keratotomy behaves exactly like any myopic treatment. You haven't removed tissue, but you flatten the center so the epithelium thickens. It's about the change in curvature of the stromal surface, not about whether you took tissue out. And that's why orthokeratology also works by epithelial squashing. This lens squashes the epithelium in the center and produces flattening of the cornea, which is reversible when the epithelium recovers. Now, I want to go here through this slide in order to separate and clear up some big confusion in the industry about what's called wavefront guided and what's called wavefront optimized. Because companies have been rather dishonest, I would say, about their nomenclature. The truth is that we all know that if you treat a -10 with a Munnerlin profile in 1995, you're going to introduce a lot of spherical aberration in the cornea, and this patient is going to see badly at night. So we were promised that if we measure that wavefront inside the patient's eye and put it into the profile in a mirror shape, we will prevent the induction of spherical aberration or treat the post-op excess spherical aberration, so-called a wavefront guided treatment. But what came out of this, and we've published one of the studies on this, is that you only get about a 27% reduction in our study, 27% in spherical aberration. You don't flatten the wavefront, which is what we were promised, if you all remember. So then, when we got this minor effect, we said, well, let's just take the wavefront and multiply it by 1.5 or by 2 and stick double and see if that works. Well, unfortunately, if you do that, you end up getting less spherical aberration, but you start getting central islands because now you're digging a trough of spherical aberration and the center is no longer compensated by epithelial thinning, and so now you're getting central islands, as you've seen with Q sliders and whatever. So that's actually not a solution. The solution, of course, is to take more peripheral tissue without creating a central island so that you can induce much less spherical aberration, not get central islands. And here's an example of a profile that we developed at our clinic for Zeiss, where the optical zone is 6, we get 6, and this is a -925 correction because we have added peripheral ablation. Most modern Lexmer lasers are doing this now. Nidec, Schwinn, excellent ablation profiles because they're taking far more peripheral tissue out from outside of the optical zone of the laser. It's not about what you do inside the optical zone. It's what you do outside of the optical zone for the peripheral expansion. And let's be very clear. You cannot take, even if you take the post-op wavefront and put it into the patient's eye, you only get 27% effect. If you're measuring the wavefront of a nascent eye with practically no spherical aberration and putting that into an ablation profile, you're going to have 0 significant effect on the end result of spherical aberration because it's related to how much you're treating. So wavefront guided is not better than wavefront optimized unless you are putting the patient's pre-op wavefront onto an optimized base profile that doesn't induce as much spherical aberration and the pre-op spherical aberration was significant. Because if it isn't, then you're putting nothing into something, so you can't get more. I hope that makes it clear. So wavefront guided is not better than wavefront optimized. Forget that. Wavefront optimized is critical, and wavefront guided is an option if the pre-op spherical aberration is significant. Okay. Having put that to bed, I'm now going to call up Glenn Karp, who's going to continue with what do you do about this spherical aberration? So how can you repair this? What are the modalities available for us to do it?